Okay, it's 5:30. This is Garth Gulick filling in for Mike Prini, who has not been able to get his computer to work. So I will be introducing Michael Tutu as our guest speaker. And first, Mike would like me to remind everybody to please mute your microphones if possible, so that we can hear our speaker uninterrupted. These slides are offered free for this moment. In the future, it'll be a part of membership to have access to them. And the recordings are the property of the ACCP. With that being said, I'd like to introduce Dr. Michael Tutu and our talk on managing dental emergencies and corrections.
Michael, you're on mute.
Yes. Good evening and welcome. In any correctional settings that you find yourself, dental emergencies will happen. And so this evening, we are going to look at most of the common ones. I know it's a very broad topic, and I'll try and do justice to as many areas as possible. Please reserve your questions towards the end. At the same time, we provided our email addresses if you have further questions that you could contact me or Mike, and we will be able to provide you with answers. When I started in the profession close to 40 years ago, people used to talk about, is there any true dental emergencies? Any dental condition that requires an immediate evaluation and treatment necessary to prevent death, severe or permanent disability, or to alleviate or lessen disabling pain is a dental emergency. And the condition, as we will see later, could be life-threatening. Emergency conditions may include fractured jaws, other traumas, swelling, uncontrolled bleeding, and that could remain acute if no intervention is provided. We have urgent conditions that may interfere with normal daily activities, but which include constant pain, that can disturb sleep. So I will show you in the course of this presentation how that could happen. And routine conditions, dental conditions such as we always get, I would like to have my teeth cleaned. Our dental conditions very serious. I hope you can see this happening here. Sorry, let me move this out of the way. Oh, this. Oh, you can see my screen, right? Mm-hmm. Okay. In 2013, the American Journal of Endodontics did a study that shows that several people are admitted to the hospital because of periodontal abscesses. That's the infection that comes out of the root of the tooth. And we have recently seen several people dying out of even common toothache.
Recording in progress.
In 2017, there was a truck driver, Vadim, from Sacramento, who was going to New York. He had a toothache before he started. By the time he got to New York, it was bad. So he called his brother to come and join him to drive back home. He was admitted in Utah. And by the time he was discharged to get home, he couldn't make it, and he passed on. You all heard about Devontae Driver in 2007, that young lad from Maryland, Prince George County, who had toothache turned into a dental abscess. And of course, most of these abscesses sometimes are not even identified during autopsy, brain abscess, but the source could have been from dental or tooth infection. Closer home, in 2004, Anthony Shumick was at CDC that's California Department of Correction, Solano. He had a wisdom tooth removed, and it turned into serious abscess, and he passed on. So these things can happen, and they do happen. Oh, can you see what happened? So what do you do? Just like all our encounters, your patient interview is essential. You want to know if there are any recent facial injury.
Yeah, no, I need to be helping you work on these.
And you want
stuff.
to know from the patient, from 1 to 10, what's the level? Any difficulty breathing or swallowing, this is very critical.
Be on
You
another
have
Zoom in
to ask
30
that
minutes.
question,
This only has
Please
30
mute.
especially
battery.
in
Please
swellings,
mute
in
your
dental
computer.
swellings. Any spontaneous bleeding from the mouth, those are things that you need to know. And of course, not all wires in the mouth, as the nurses usually encounter, are orthodontic appliances. Sometimes the patient might have had his jaw broken and never went back to get it removed, get the wires removed. So these have to be checked and taken care of. Of course, you always want to make sure that these days you have your PPE ready. The first thing I do, and the first thing is to check the face. For the most part, and for most of us, our left and right side of our face usually seem the same. But as you can see from the patient on my right, the canine fossa, or the right side of the cheek, is all swollen. And that immediately can clue you into what is going on. You can ask further questions. Lips that are swollen, swelling underneath the eye, and you can see a sign of injury here. Bruises all over with a swelling around the ankle of the mandible here, as you have seen over here. Swelling from the tooth that I will show you where these are coming from can get down to the neck. And sometimes it can get so severe that this patient on my right will not be able to swallow or breathe. This is a life-threatening situation, and this patient needs to get to the nearest hospital and by the fastest route. Because as you can see, you cannot discern between his neck and his jaw. As you work your way down, and as you will notice, most skin infections or most infections that have skin involvement usually have oral involvement as well. As you can see from here, all these lesions on the lips or around the lip has a component within the mouth. So as you see or you look around the face and sometimes on the skin anywhere, try and take a look inside the mouth too in your assessment. Don't be scared about the things that look so obvious and so scary.
Yeah.
This is just a simple poor oral hygiene and a patient who has been on Dilantin. This tissue is very firm. Of course, the dentist is going to cut off all those things and reshape it. It's a chronic condition. It's not an emergency. If you look at this case on your right, on my right, it looks like someone took a knife and shaved the gum away, straight almost. You see the inflamed line around the margins of the gum. This is more serious. This is what we call acute necrotizing ulcerative gingivitis. This patient will appear to you or present to you spitting all the time, dehydrated, have no appetite, have temperature, and he looked sick. He needs immediate intervention, including antibiotics, fluid intake, diet, and all that, and close monitoring, because it could turn into something more serious. Of course, you're going to see things that looks like, where is this? But that's somebody who has never paid attention to his teeth. Okay.
Please
so
mute.
The teeth will be loose and they may be falling off. As we will talk later about teeth falling off or how to replant a tooth, something like this, you will not be able to do anything about it. Not too long ago, we were seeing this, and we still continue to see this. This is a patient I saw in my private practice. Of course, he had just gotten out of our institution, and his mother had referred him to us. And what he told me was very eye-opening. He said the crazy dentist wanted to pull all these teeth. Of course, you don't need to be a dentist to identify that these are not viable. Meth mouth is still present. So this could point you into your substance abuse, substance use disorder investigation or analysis. And this is what happens. He has a bump around here, and we will see him later. You're working your way down from the outside, and you get into the mouth. You've seen the teeth. You look on the roof of the mouth, and you're looking at the tongue. On the right-hand side, you will see this tongue very black. It's scary. It's not melanoma. It's just poor oral hygiene. And I guess all of you, some of you may know the name. It's called hairy tongue. Whenever you see a lesion in the mouth, this colored lesion in the mouth, and you're concerned about it, just take a cotton ball and wipe it. This one, when you wipe it, it will come out.
Somebody is not muted. Please mute. Please mute your computer.
It will come off. Just as with all other lesions on the surface of the mouth, take a gauze, wipe it. For example,
Julie, you are swearing. Please mute. We can all hear you. Please, Julie, mute your computer. Thank you.
So if you wipe it off, for example, in candida infection, if you wipe it off, it will leave a raw bleeding surface. That's a sign that you are dealing with something else. But in this case, no. We are seeing more and more of a tongue with this growth on top of it. This is from tongue piercing and using cheap jewelry. And you will be seeing this more and more. And this can look threatening to you, but there is no pain associated with it. It bothers the patient by just being the way she moves her tongue. On the right-hand side, you're going to meet this patient later on, but her story is simple this. About a week ago, she bit her tongue and had not been able to eat. When you check the nose could be fixed all around the neck. This is a more serious problem. And let me give you a clue. I mean, a key that I use. It's called Route 66. Of course, I used to live in Arizona, and that is Winslow. So Route 66 is, if I see any lesion and I am observing or managing, and in 6 to 7 days, I haven't seen any progress, I'm either first taking a biopsy or sending that patient on to somebody else for all soft tissue lesions in the mouth. The second 6, which is 6 weeks, deals with my fractures. If I'm not seeing any much progress, it means the intervention didn't work, and it has to be. But we'll discuss further on that. In your screening or in your review or assessment, preliminary assessment, make sure you check the functional ability of the patient, such as being able to open their mouth. Mouth opening is about 35 to 55 millimeters, about 1.4 inches to 2.2 inches. Men can open much wider than women. So let me leave it there. So in summary, this is a form that you can use. You check your vital signs, you check the facial symmetry, swelling, trauma, signs of ulcerations in and around the mouth, decayed teeth present or not. Can they open their mouth? Do they have difficulty? This is very, very important in swellings and in even traumatic injuries. Do they have any difficulty swallowing or breathing? If both are present, it means the patient needs to be moved on to the hospital. You may not be able to help. Loss of sensation, decreased fluid intake, and your comments. So now that we've taken a look at what happens with these initial assessment, let's dig a little deeper into looking at some of the most common correctional dental emergencies in correctional settings. We'll take a look at the toothache, tooth decay, acute dental pain, swelling. I have put in a few other infections that are of interest, fractures, teeth that had been knocked off, and after dental extraction, bleeding. That is very common. I have given you a schematic for drawing and blame my art instructor from high school. And for the tooth looks like an egg, a boiled egg that you have cut into two. You have the outer shell, the enamel. It's just like the egg shell. It has no nerve in it. It's harder than the eggshell, of course, to protect what is beneath it. The next layer of tissue is the dentin. It has tubules in it that also contain nerves and blood vessels and other things, but they are very tiny. When a decay gets from the enamel into the dentin, that's where the patient will present to you with sensitivity. And when the stimulus is removed, the pain goes away. If he's drinking cold water, it's sensitive. He's eating sugar, it's sensitive. But when those are gone, so it stays in the dentin. The dentist will fix it, and that's the end of it. But when it gets into the middle, of course, the egg yolk or the pulp, that's where all the activities are. And as you can see, you have a hard surface around it. And so when things get into the pulp and tissues start breaking down, that's where the patient will present to you with pounding, throbbing, stabbing, and shooting pain. And the pain gets worse. When they lay down, because pressure is equalized, the pressure in the head increases to the tooth. And therefore, he hears the pounding and gets up. But there is an African saying in West Africa that the eye has no sympathy towards grief. You know, you will always go to sleep no matter what. So you go back to sleep and you wake up. So the patient will present to you, I was not able to sleep at all. And if the patient sometimes may have even systemic involvement, fever and other things, where you may need to intervene with antibiotics, pain medication, and send him on to the dentist. So one thing that I want to bring to your attention is called cracked tooth. Even in the hands of experienced dentists, this is very difficult to identify. It is associated with chewing. The patient will tell you, my tooth hurt only when I chew. And it gets worse, you know, and the pain could be throbbing, but there's always a history of trauma, either from chewing, I bit into a bone or something, and there is a sign of bruxism. Bruxism is where the tooth is worn off, grinding the teeth. And you can see that the front teeth, instead of having the specks on top of them, is very flat, very flat. And the back teeth are also flattened completely. Sometimes you cannot even see any cast. And that is when the patient describes something like this, he has to immediately be sent on. Because in 1990, I believe it was 94, the American Medical Journal presented a case. Someone presented a case, published a case, whereby this guy went to a restaurant, he ate sausage, according to him, and he started having swelling that radiated from the neck and into the mediastinum. He had to spend several months in the hospital, and they couldn't trace it down until later on after discharge, because the infection continues going on, that the dentist was able to come in and then take the tooth out. So pay attention to that. These infections, as I show you from back to the tooth, from here, it can get into the bottom of the root of the tooth and then become localized. As you can see from this tooth, heavily filled, and you have a local infection, from this heavily filled tooth. It's localized, associated with that tooth. And let me see if I can. Here you have a localized infection. The same thing with the pulse here. This is a swelling associated with the wisdom tooth that has no space to come in. And you can see that the soft tissue above it is swollen. These are localized infection, and I will show you how to handle them. Most of the localized infection will, I think, I'm not sure. Oh, okay. Most of the localized infections can resolve by treating that tooth alone and does not require antibiotic, for example. Okay. Chronic periodontal disease, for example, will require cleaning. Or if the infection is into the middle of the tooth, we can either remove the tooth or do a root canal treatment for it. And for the wisdom tooth, let me go back. For the wisdom tooth here, just irrigation will resolve that for you. What do you do to this localized infection? You have to use your knife, go in there, and then do an incision and then drain it. Here is the steps that you can take. And you can do it as a physician, as a dentist. For a localized infection, most dentists will attempt to do that. Here is the swelling. You take your 15, you get into it, and then I need to move this away. Okay, so you go as far as you can, undermine the tissue, and then you cut a piece of rubber down. Put your suture through it, and then push it into the incision that you made to form a drain for you, and tie it into the soft tissue to stay on for about a week. And you will have, after the week, you take it off and the tissue will be almost healed. This is what you can do. So I need to move this. How do I get rid of this? Okay.
Can I help with something?
Can
I help with something?
No, I'm trying to get rid of this. Can you see my whole screen or?
Yes, we can see, watch for signs of a spreading infection.
Oh, okay. I have something on that is blocking that. So you have to watch out for signs of spreading infection. It's very important. The first 72 hours, 48 to 72 hours will tell you how things are going to go. And therefore, if you're concerned, make sure that you have a daily observation. A nurse can do this and report back to you. Any dental infection can be serious. And your goal is for a localized, to prevent localized infection from turning or becoming systemic and life-threatening. So your concern is that your concern for airway obstruction, as I show you by the gentleman with no neck, infection going into the mediastinum, like the gentleman who bit into a sausage, cavernous sinus thrombosis from infection from the face, leading on into brain abscess. So you have to always look out. And let me go back.
Oh, okay.
There are several facial spaces in the mouth. You have the vestibular, which is between the cheek and the gum. You have the canine space on the front, the buccal space, and then the submental in the front here. Sublingual is between beneath the tongue, the front 2/3 part of the tongue, and the submandibular is usually the back below the tongue. And let me take you back into the memory lane on your anatomy. We will get back to that, where the submandibular is divided. And here you have the vestibular space being filled, between the cheek and the gum. You have an infection here from this tooth that pass through the bone and then get into the vestibular space. Of course, from the tooth, either in the top or in the at the bottom, will move into the buccal space, and here is the canine space. You see that,
Michael, we don't see your screen at this point. We don't see your screen now. We don't see your screen right now. We don't see your PowerPoint.
Really?
Go down and hit share screen again.
Oh, okay.
The green arrow at the bottom.
Can you see it now?
No, it's not showing up.
Mike, can you see it? Can anybody see it?
No, we don't see your
We see
PowerPoint.
canine space.
Yeah, but you see the picture, right?
Yeah, we see a picture of an
Yeah,
individual.
Mike is
Okay.
probably.
Thank you. It's not working for me. That's fine. Go ahead.
Okay, so here in the canine space, you can see that it's filled up completely. And this is a very dangerous infection because it can transcend underneath the eye onto the brain, and you can have cavernous sinus thrombosis or brain abscess. The submental space, as I showed you, is in the chin. And let me take you back to memory lane. The submandibular, sublingual space is usually between the inside of the lower jaw all the way towards the premolars. And usually it's separated by the mylohyoid muscle. That separates that from the submandibular, which is where you have most of the molar roots into. That's where when you have infections in the wisdom teeth and beyond, you are so concerned that you could turn into the thing that I showed you. And the space is bordered interior in the interior side by the medial pterygoid muscle. So, and here you have the submandibular space. You see from the infection around the neck, and it can get as bad as I have already shown you with difficulties breathing or swimming. What you have to do is to determine how rapid and urgent this infection is going, which will include, is this extending? Is it affecting breathing? Is it affecting swallowing, speaking? Is the eyes involved? Is it fluctuates? How fast is the symptom continuing? So you want to look at all those things to make sure the involvement and how rapid this is coming on. That's where your 72 hours is critical. We prescribe antibiotics in dentistry. Of course, in 2015, and a study that was done found out that dentists account for 13%, about 3 million of antibiotics prescription. We throw antibiotics to everything, unfortunately. And of course, old faithful penicillin tend to be the first order of antibiotics we go to. And what you see is that some studies also show that we prescribe antibiotics incorrectly because we just use any symptom, we just throw it at it. And the prescribing habits vary widely. So what do we do? First, you have to find out, is antibiotic needed? Okay. You cannot just clear the infection by just prescribing antibiotics. And in our situation, most of the time, we just do it because to cover ourselves. But we have to be careful with doing that. So what is the standard of care? Patients with spreading infection should be prescribed antibiotics in conjunction with the removal of the necrotic tissue, as I showed you, with the local incision and drainage. You are removing the necrotic tissue. And you want to monitor the patient closely. That's the standard of care. And the current best practices, you prescribe the antibiotics according to your current guidelines.
The only reason I'm
Best
doing
assessment, you have to determine whether this is localized or is systemic. And is the patient immunocompetent? All those things have to go into your calculation. And if the infection is spreading, patient is not improving, you have to refer promptly. As I told you, our first line of antibiotics tend to be the penicillin, old friend, old faithful. Amoxicillin is now being mostly prescribed because of his 3 times a day dosage, augmenting in our situation because it's twice a day dosing, and clindamycin, we don't use erythromycin anymore. And so clindamycin, azithromycin are being used. And it all depends on the duration, usually is 5 to 10 days. And it depends on the severity of the infection you are dealing with. As I've told you, we use amoxicillin more now because of the efficiency and the therapeutic value beyond better than penicillin, and clindamycin as an alternate for those who are allergic to penicillin. Of course, I've mentioned azithromycin, but don't hesitate to use IV antibiotics. If after the 48 hours you are not getting any response or desired response, you should know that in our system, our patient may not even be taking the medication. Somebody may have taken the medication from them. You want to be sure that you are admitting the patient to an infirmary and administering IV medications so that you can support what you're doing and intervene appropriately. There are several ones that you can use, and I've given you examples of them here. Be mindful. I understand there are some nurses on the line with us. Please be mindful of the side effects and monitor. You probably don't do that very much, and we should be doing that. So for my summary here for antibiotics is when you prescribe it when the infection is spreading and has a systemic involvement. Drainage and removal of the source is critical. And monitor the patient, be aggressive and vigilant with infection involving the lower molars, as I have already shown you, can get into a situation we call Ludwig angina. Patient will not be able to swallow and patient is not able to breathe. And it's a very life-threatening situation. So now let's take a look at other infections. I've already mentioned, we've already met this gentleman with the ulceration in the mouth. What do? We now have in every pharmacy, or every pharmacist have their own miracle mouthwash. In Phoenix, we have St. Joseph mouthwash, which is from St. Joseph Hospital. And it's just an equal parts of triamcinolone solution, tetracycline, diphenhydramine elixir that is dissolved the tetracycline. And then you have xylocaine also added. And you shake it well, patient swish and swallow. For most lesions that you can see on the surface of the mouth and around, there will be multiple sites, and therefore swishing and swallowing may be the way you want to go, because it could even go into the back of the throat, and therefore you will be able to make the whole place numb, and the patient will be able to eat and swallow well. The other infections that I mentioned earlier on, like this gentleman on the left, note is a lady, is one of my patients, very non-compliant with the HIV treatment. And you can see how much candida infection in the mouth. All that you have to do if you are in doubt, take a cotton gauze and just try and wipe the surface. And you can see that it will be leaving you a raw bleeding surface. This patient, for example, if you have something like this, is going to be a teamwork. For the dentist, you will need the intervention. It's a non-compliant patient, so your mental health has to come in. Your physician and your HIV group have to come in, and your nurses have to be on the team with your pharmacist so that you can monitor his case. I've already told you what to do with this acute ulcerative necrotizing gingivitis, so I'm not going to bother you more with that. And here, with the patient, these patients I've already discussed, make sure you remember Route 66. They told you that it has been there for a week and it's not getting any better. If you bite your tongue, most of us do that from time to time. Within a week, it will be doing better, even without doing anything. You need to send this patient on to get a biopsy. If the dentist is not comfortable doing it, you need to see an oral surgeon and get a biopsy. I had a patient who had half of his tongue taken off about 8 years ago, and he's still enjoying life. If it had stayed, we probably wouldn't have had him. Here is a case that may happen in your institutions. This young boy was out of a dare, decided to touch a hot pizza with his tongue and got burned. So he was sent to my office, and here is what we did. We put, I put Kenalog in oral base over it. Of course, I put topical anesthetic, put Kenalog in oral base on it, and see what happened in a week on the right side. The lesion is almost gone. Route 66, don't forget that. So now that we've gone through these lesions and infections, let's also take a look at traumatic head and mouth injuries. There are always the obvious deformity, but I want you to pay attention to three things in the presentation. The patient will tell you, my bite is off or my teeth don't come together. At least certain part of the jaw is hurting and they cannot feel certain part of their face. Even if everything looks normal, these will point to a sign of a fractured jaw. In your assessment, always try and eliminate higher priority injuries. What are these? You may have brain trauma, trauma to the skull and resulting in trauma to the brain. Sometimes we get so glued to the obvious things that we are seeing, like a tooth that has been knocked off, without looking around. Always pass your hand around the head, because there may be a bump somewhere. On the football field, we find our place is the only place where soccer is so violent that there are always people knocking somebody off. And it's soccer match. So pay attention to high priority injuries. Your vital signs are important. Document the history of the injury, especially find out loss of consciousness. They know where they are, the time, and also any vomiting or nausea associated, or any headache. These are very important. Any difficulty opening their mouth or closing. Let me see. And these are very important for you to do. For orbital and zygomatic fractures, the zygomatic fracture are the cheekbone fracture, they cannot open their mouth. For orbital fractures and fractures involving juveniles, please make sure these patients are seen in the hospital or by whoever is going to intervene or do the treatment. See them within 72 hours. Because for young people, the healing is faster. And sometimes if you wait for the week, like we can do with an adult stable patient, the surgery becomes more difficult, as I've been told by several oral surgeons. For fractures around the eye, you will see that the muscles may get trapped. And therefore, after a certain number of days, 72 hours, the vision may not be able to be set right. So make sure you intervene quickly. So I've shown you a fractured jaw, and then you can see the bleeding. Of course, in this case, for example, even though the jaw is broken, I mean the upper teeth from the alveolar bone is broken, but you can see that they are bleeding. There's bleeding from the nose. Use cotton gauze to take a sample of all bleeding coming out of the nose. Put it to the side. If it dries out and you have a halo around it, you have a CSF leakage, which is a higher priority than all the things that you're doing. And your hospital need to know so that they can assemble the team that need to intervene before the patient gets there, okay? Fractured jaw often, most sites are at the lower jaw site. And when you are hit on the left side, sometimes the upper jaw, the neck of the condyle is where the fracture is. So you can see that here is 20 on the opposite side. So while you are worried about the swelling on this side, always also check on the other side too. Here are two gentlemen. I later found out that they were roommates. Here you can see a real sign of bruises, swelling on the left side, and everything, the lip. Here is another gentleman. He has just a slight swelling over here. The one on my right came in the morning, and this one came in the afternoon. The one on my left claimed his jaw has been coming numb since morning. The officers have had a training about a heart attack, so they immediately rushed him to the dental office because all other things were okay. And that was the picture I show you with blood in his mouth. And the x-ray, as I'm going to show you, which tell you the story. Here is the gentleman on my right. You see he had periodontal abscess. The tooth, the molar had no bone support, and that's where the swelling is. The gentleman on my left had a fracture around the side of the jaw. And so that will tell you about. Lefort did some experiment, and here is what he found, that the jaw may be broken into several places on the top, but the facial fracture with Lefort 1, 2, and 3. Oh my. But notice that there are several different bones within the upper face. And so don't restrict yourself to the one area. When you see this as it has been fractured and you are bleeding, there is a bleeding from the mouth, and you are taking a sample, please do not use Q-tip into the nose to try and dry it, because you may be penetrating into the base of the skull, because the fracture could have cracked the base of the skull. A patient like this, make sure you don't use a Q-tip to try and clear the nose for him to breathe. Send him on. Make sure you take a sample of the blood coming out of the nose and help out. Okay, so what do? You ensure that you are supporting the airway, cardiovascular, cardiopulmonary stability is there. What you can do is to rinse out all the debris, control bleeding. And I will show you how best to do it. Take a piece of, take one glove, fill it with crushed ice, like I've done here, and put 1 or 2 fingers into the mouth where the bleeding is coming from, like this. And then rotate the others onto the surface. It's very easy. And try that. It helps. And you put it on 20 minutes on, 20 minutes off. Keep the patient NPO until the determination is made as to what to do. I've already told you about juveniles and that. Your patient may come out from the oral surgeon with wires in his or her mouth. What do you do when they come? Use the ice application that I've told you. Medications will be recommended. My recommendation is, before these things happen, establish a relationship with your local hospital or your local oral surgeon so that they are aware of your formulary, because you don't want a prescription that you are now going to scatter around to look for. They know what is available and what can work for you. So establish that relationship. Does the patient need to be in an infirmary? Not necessarily so. You can put them closer to the control room where they have the wire cutters. In all the close to 40 years that I have practiced, and I've worked with several oral surgeons, none of them has ever reported on the street that my patient felt like throwing up, so he used the wire cutter. They will return with the wire cutter still in the sterilization bag. But if it's the first one is going to happen, I will sure tell you it will happen in our environment. And so you can keep them closer to the control room with this thing. But for safety, you may keep them in an infirmary if you have one. Invest a little bit in your oral hygiene. Right these days, you have electronic toothbrush. The patient can easily brush around all the food. It's very difficult to use those correctional toothbrushes, security toothbrush that is about 2 inches long, to get it to the backside. By the time the patient gets out of the wires in 6 weeks, you have another serious problem. Your dentist is going to spend a whole lifetime trying to restore what is the decay that has come on. So what do? Eliminate. So you've done all that and you are taking care of that. Let me quickly take you through, within the next 5 minutes, through a tooth that has been knocked off. Of course, while you are looking at the tooth, if the patient is lying down, pass your hand around. There may be a knife behind his head. And you are just looking at the tooth that you're concerned about. Higher priority injuries first. Maintain airways, document the history, especially loss of consciousness, because if the patient lost consciousness on this field, felt nauseated, doesn't know where he or she is, please keep him closer at the health unit and monitor. Don't send them on to their yard or to their bed dormitory, because you may not have them the next morning. So pay attention to that. Sometimes the tooth is knocked out, it's hit, but it's in the mouth and it's loose. So you just keep it in the mouth, push it into align with the others, stabilize it, and have the patient bite on a gauze or a tea bag. I will recommend a black tea bag because it's easier to use and it doesn't thin out the blood so that they will not be spitting out. Consider pain medication and soft diet if necessary. But when the tooth is knocked out, the best thing to do is to put it back in as soon as possible, as I'll show you in the next screen. But if it cannot be put in, make sure you handle the tooth by the crown, which is the top part of the tooth, not by the root. Don't scrub it and don't wash it, okay? And you replace it, if you can't put it inside the mouth, put it in a gauze and wrap around it with a dental floss or a thread. If you're on the field, pull a thread from your clothing and just thread it. For if you have a younger kid or somebody who is not able to follow instructions, make sure you tie the end of the thread to a button. So if they go to lunch with it, you can pull it out. You know, if they attempt to swallow it, it's very critical that you don't have a second problem by doing that. And transportation, if you are taking it to a dentist, the best thing is, as you wrap it around, put it in on the cheek of the patient and tie it to the button. As I said, if you can't do it, the patient's saliva is the best solution for this case. You can use milk, as has been suggested, but don't use reconstituted dry milk, because the drying agent in the milk can make things worse for you. Nobody walks around with save a tooth saver, but if you have one, that could also help. They are in the order of the patient saliva milk, tooth saver, saline, and sterile water. The best prognosis is to have this thing within an hour. Here is what the dentist would do. Once the tooth is implanted, they will use a paper clip or ligature wire and stabilize the tooth to stable tooth. This is a patient who came in from the basketball court that had his tooth knocked out. He had put it in on the court, and so I stabilized the tooth. And that's the picture of it. So it could be done. So,
Michael?
Yes, I have
5
I
minutes.
have about 7 minutes.
Yeah, okay.
Right.
And for
So I'll be
questions. Yep.
wrapping up soon. Let
Doing
me
good.
quickly
Thank
talk
you.
about bleeding, post-operative bleeding, and that is all these causes of bleeding are very familiar to you as physicians and nurses and dentists. And one of the causes are from the S. This is my case. I took out a tooth and you could see the bleeding from the side. And one thing that happened more common in our area is blunt force trauma. Somebody putting padlocks in a socks and hitting another person. As you can see, this is very difficult to control. So all that you're going to do is to put eyes on, pack it. If you do not control the bleeding, you will have what we call a liver clot, and it can grow like a mushroom. What you need to do in this case is to take a knife, number 15, and cut it off. Clean the area, irrigate it well, and then pack it. So these are the things you have to do. You place the patient, you put the gauze in, 2x2 gauze, make sure it's just enough for the patient to swallow. And then he will keep swallowing his or her saliva and not to spit. I'll give you an example. The picture on the left, you see that the gauze the gauze is completely filling the space where the tooth came from. My destiny is not moving. But on the right side, you see that the destiny is not filling the space. So that is the wrong placement. You would discharge the patient, have them continue with the ice placement like I showed you, and restrict activities. Smoking, as the nicotine will interfere with the healing. Just a word and I'm done. Tooth that are broken. Here you have an example of, on the left, you could see that if you look in the middle and you can see the pulp, cover the patient with antibiotics. It's painful and pain medication until the dentist can see it. It may result in root canal treatment and then restoring the tooth. On the right, you see that it's just the tip of the tooth that is broken. The patient may tell you it's rough to the tongue, but it's not sensitive. Enamel, as I showed you earlier, would be what has happened, and the dentist will restore it to function. Thank you very much. And here are the references. And if you have questions, I'm ready to answer some questions for you. And here our email address, snag@yahoo.com, is for Mike Pironi, and Michael Edututu@msn.com. You can contact me. Thank you very much.
Yes, and I'll say that. Thank you, Michael. Thank you very much. And thank you to Garth Gulick, who at the last possible moment with the leaky roof agreed to begin moderating. I had a glitch with my computer, a totally unexpected event. Use my email to contact me about any future sessions you'd like to see. In 2 weeks, we're going to have Rebecca Ballard, Dr. Lubelzik, talking about orthopedic injuries and stretches that she's found useful, especially in chronic pain. There are a couple of questions. First was about the use of triamcinolone dental paste. I think you alluded to that after the question came in and said that you use that frequently with any ulcerations in the mouth to see if in 6 days they're healed or at least making progress. So that's not essential. The second question was about, so I think that most physicians are hesitant to do surgeries in the mouth, to take a biopsy or to do that procedure that you showed us with the drain.
Yeah.
Somebody was asking, where do you get the drain material? I think that most facilities can get you that.
The dental rubber dam is always available at your dental clinic.
Yeah, so if you ask your dental clinic, one of the docs was asking, I think Dr. Wilkes was asking about that. I think that'll work.
It's one of the things we use when we're doing root canal treatment. And so these days, general practitioners tend to do root canal treatment.
Do you have a feel for liability risk for a primary care physician trying to do a dental abscess? If the dentist isn't coming in,
the primary care physician, the MD, if you look at the licensing requirements, they can touch everything. The reverse is the dentist.
Yeah, and so talking to your dentist and maybe getting a little, maybe observing one or something. Yeah.
Because for the most part, dentists are not available like we have physicians available in some of our smaller institutions.
My take-home lesson for all that is you can do it, and just don't throw antibiotics at an abscess. The same way an abscess anywhere else, right, Michael?
Yes.
And so I had a question myself, and so I think we touched on the questions that are in the chat area. I had a quick question. I didn't understand how to distinguish. You were talking about a CSF leak, and I missed that part, or I didn't understand that part.
What I was saying was that when there is a CSF leakage, when it's mixed with the blood, and you take a sample, a drop, and you put it on the side to dry, you will see that there is a halo around the core, the center of the dried blood. The CSF will form a halo around it,
Around the blood.
around the
Understood.
blood.
Understood. Thank you. Thank you very much.
And so
Then-
it's critical. And if you have that, you want your tertiary institution or wherever the patient is going to be aware, so that they will get your the neurosurgeons and all the people that they need available.
So then the last tip that you gave us that I didn't understand well was about a button to keep the person from swallowing the tooth that you've reimplanted.
Yeah.
How do you
said
do
was
that? What's
you take-
on the ground? How do you do that?
Yeah, you take a gauze, assuming this is it, and you put the tooth inside, and you use a thread to tie it around it, and you put it in the patient's cheek,
Ah,
and the end of the thread is tied to the button.
and that way,
Well-
if they've got it in their mouth, that's a good safe place
Sometimes
for
they
it to
will be
be on
playing
the
with
way
the
to the
thread,
hospital.
with the everything. So if
Understood.
you want them not to, so if it's going on like that, you can pull it out. Because you
Understood.
tie it well, especially for younger people. I did a training in Sacramento, and one nurse was talking about how it happened, and she had heard me before in one of our conferences, and how they did it to get it to the dentist within the hour, and the tooth was still in the patient's mouth, her daughter,
Well, thank you, Michael. That really, I get it. Thank you very much. Michael has told me that he'd be willing to share his slides, especially those evaluation slides about what he looks for in various conditions. They had a lot of information on them, and we went through them pretty quickly. And so if you need those or want those, email to Dr. Tutu, and he will get them to you in a format that you can use.